Welcome to the Terminology Leading Practices stream. So those that are in the room, I have to read this every time for those people online. So it's not that I've forgotten to read this. At Expo 2025, thank you for TermMed for sponsoring this stream. My name is Ian Spires. I'm a terminology education specialist at SNOMED International. I'm your moderator for today's session. We'll address all questions at the end of the presentation. Those online have the ability to ask questions through a Q&A button. Those attending here, at the end of the session, we'll put the mic, which will move across, and you'll be able to answer questions through the mic so those people online can hear it. So today I'd like to welcome Annabel and Kim, who are going to talk about data capabilities, SNOMED CT and FHIR as a foundation for an interoperable standardized EPD. So Annabel and Kim.
Thank you, Ian, and hello everyone, I'm Kim. I'm a little bit nervous because it's my first time presenting on SNOMED CT Expo. I'm from UZ Leuven, which is a pretty big hospital here in Belgium. I have a background as a nurse, and a couple of years ago I switched careers and I got into the SNOMED CT team from UZ Leuven.
My name is Annabel. I work as a software engineer, mainly on FHIR and the use of FHIR, mapping to FHIR. And yeah, that's it, I think. We can start.
Okay, how it started. Our federal government issued data capabilities projects, and there were some very intelligent people in our hospital who thought, we're going to do something with that. We have an objective. The objective is to improve interoperability and reuse of clinical data. And we're going to focus on what we have already in our EHR system. So the context of the project is we have an EHR system, which is a KWS, KWS, Klinisch Werkstation in Dutch. And it has existing structured data, but a lot of existing free text. For a data capabilities project, we need semantic and interoperable, semantic and structural interoperability. Why? We want to exchange data, and if possible, we want to use our mappings and the work we are doing for research, for data analysis, for quality indicators, and so on. Okay, interoperability, a word that it has a lot of people talked about interoperability, but you have different kinds of interoperability. You have structural interoperability. That's how are you going to exchange? We make an agreement on the data format and the structure. And we have a semantic interoperability. That's where the language comes in, SNOMED, LOINC, etc. Why SNOMED? Do I really have to do this slide? Because we are on a SNOMED Congress. I do think everyone here in the audience knows why SNOMED is important. So I'm not going to read everything on the slide. I do know that everyone here is convinced that SNOMED is a very good tool to improve data analysis, improve data quality, improve reusability, improve standardization, etc., etc.
And the same thing a little bit with FHIR. I hope most of you already heard of FHIR or know what FHIR is. But it's very modular. You have these different resource types where you can put in different kinds of information. And it's well aligned with SNOMED CT in the sense that you can easily enter different coding systems, different terminologies, and input them into your resources. It's also very future-proof and it's widely supported. There are many versions that are being sustained by the International HL7 organization. In Belgium, the preferred terminology is SNOMED CT. And the government has also given us a lot of opportunities to work with FHIR and work on FHIR mappings. There are different working groups where we try to figure out a Belgian standard on how to model our data into FHIR. So the vision there is going towards FHIR and SNOMED. And of course, if you bring those two together, so FHIR for the structure, the data structure, and SNOMED for the semantics, you have this beautiful piece of information that you can exchange with other organizations and can be easily understood.
That being said, the route, yeah, how are we going to do this? What can we do with what we already have in our system without interfering in clinical workflows in a very huge way? So what do we have? We have fragmentation of clinical data. We have limited standardization. We have legacy codes. We have free text. We have a lot of things, and we have a lot of limited reusability. So we defined two routes, and that's because of there were two paths we are walking down at that point. One is we have our legacy codes. We can map them, the background, to SNOMED, and that will have a minimal impact on clinical workflows. We do it in the background. Nobody knows what we're doing. And then we have another thing, and that was a strategic project that was already happening in our hospital, where we want to integrate SNOMED as a primary language in our problem list. So there were two ways we have to go. The first way was, this is an overview, so we're going to go over the steps in a minute. This is an overview of what we did for the retrospective mapping, with the arrows pointing out that a lot of those things don't go linear. You have something that happens, you have to go back, and then you go forward, and you have to go back again, and then until you reach the end point. The beginning is select the clinical domains. What are the domains where we can get structured data that we can map to SNOMED? We have diagnosis, medical procedures, we have imaging, laboratory results, we have nursing observations and procedures. And they were all selected with the idea of what is clinically relevant when our patient goes to another hospital and we want to exchange information. Second step, which codes are we going to take from our KVS? Yeah, we're going to take the codes from 2022, 2023, and only the used codes and only the structured codes. We did not take the codes from UZ Leuven alone. We also took the codes of the Plexus hospitals and AZ Groningen. Of course, they are a partner in this project. And then we were thinking, what are we going to do further? What information can we take? And how are we going to take it? First thing is, yeah, we need a FHIR resource, because that's what we said. We need structural interoperability. So which FHIR resources are we going to take to exchange? We looked at procedure, condition, observation, body site. And what we did was we made some context-specific templates. So we took the data elements from FHIR and we said those data elements, those are relevant for our use case, and we can fill them with clinical relevant information. And then, yeah, AI. We've heard a lot of AI today, and we've heard a lot of good things today. But at the moment we started our project, I think the first time we talked about it was end of 2023. There wasn't a lot on the market at that point what could help us. That was the first thing. We tested NLPs, natural language processing programs, but they didn't give us a good result for mapping. And we validated some mappings, and our the key ID what we acknowledged was our legacy codes aren't that good. So our legacy codes were used for different kinds than only clinical information. We use our legacy codes to organize our operating theater. We use our legacy codes to drive financial streams. We use our legacy codes for everything, but not only clinical relevant information. So we decided we're going to do it manually. We're going to map manually. Some examples is just an Excel file with our context-specific templates, the data elements we extracted from the FHIR resource and what we filled in. On the left side, you have the legacy codes, you have a description, and then you have the mapping to SNOMED CT. Another one from observation and from procedure, and you see there's a lot of things to do. And after mapping the codes, we had to validate the codes. If we read a code, we can think, oh, the context is cardiology, it says TOF, so it must be tetralogy of Fallot. So I think it's in the procedure context, so I think it's correction of tetralogy of Fallot. But is this right? So this was the most time-consuming step. We had to go to the clinicians. They had to make time for us to do the validation. And again, we get into a feedback loop. And then we got the technical implementation.
Yes, so afterwards, we did all the mapping and we had these lists where we have our own EHR codes that we map to SNOMED in a FHIR-like template. But then, of course, we want to actually use them. And for that, we need our EHR vendor, which for us is Nexus Health, to implement them into their software to use primarily, but also give back to us to use secondary. So for that, we worked together and developed what is called a stored procedure. It's actually just something in KWS, in our EHR, where we can input or upload the lists that we've mapped. We transformed them to a relational database kind of structure. And once they're uploaded, they're part of the database of Nexus Health. So they can use those tables primarily in their FHIR resources. At the end, they give it back to us the same way we get our other source tables in our data warehouse. We do that because we don't want to use our own mapping tables that we make, because if we then forget to upload it, we have different sources of truth. So we want one source of truth, and that's truth is in the EHR, in the database tables of Nexus Health.
So that was the first way, mapping the legacy codes. There was another route we took. Since the 1st of October, we have a phased rollout of our primary diagnose registration in SNOMED CT in the problem list of our electronic patient records. And what we did there was, we have SNOMED CT already there, but we give the ability to the physicians to refine their concepts with attributes. And those attributes also have to be exchanged with FHIR. And what we did there was mapping the SNOMED attributes to FHIR data elements, knowing that we we strictly use the attributes and the range constraints that are obliged by the MRCM. This is just an example. The severity attribute is mapped to the data element severity of the FHIR resource, laterality to BE extension laterality, and so on. It is a challenge because the attributes of SNOMED don't exactly match the FHIR data elements. So we're not sure where we're heading there, if we're going to exchange everything in a good way, but that's saying the PE care sets are still developing, so maybe there is a chance to improve those.
Yes, and then next it will be interesting to go look at some results of our mappings, but also of the use of those mappings in practice. So first of all, some numbers. So manually, there were more than 15,000 codes that were mapped in a year and a half. 3 people did this with, what was it, maybe 1 day a week they had the time to do it a little bit. So they worked very hard, and especially on the validation with the clinician. A big part was medical procedures of our own hospital. But to mention, it's important to mention that those codes, most of those codes are also being used in the other Nexus Health hospitals. So there is a big part of the database or the codes that are being used by all hospitals, and then some hospitals have their specific codes. And then the participating hospitals needed to map some of their specific codes by themselves. But so most of the codes we mapped are currently could be used by all Nexus Health hospitals. So then we want to go see how much did we map compared to the part that we didn't map. Here you can see like 3 domains. First time I saw this, I wanted to cry a little bit.
We too.
But then if you go look a little bit closer, yeah, yes. And you map the non-mapped codes according to how many times they are being registered. So this is how many times they're being used in the EHR from the beginning, so back until the 1990s. Then you can see that the codes that we didn't map are not being used that much. There is a big part that is being used less than 100 times, which of course doesn't mean that it's not an important code. It could be like a very zeldzaam, what's the word? Rare, thank you, disease or whatever. But it gives us an indicator that we did something good, probably, yes. There is another big part of our care model, which has like nursing observations and nursing procedures. And there is a bigger part that is being used a lot that we didn't map. But that's due to the fact that that model contains observations, procedures, questionnaires, skills. It contains everything and nothing. And we focused mainly on the observations and the procedures that are important to exchange between different parties. But we are going to take another look at the codes that we didn't map, if we missed something, if we want to map something else. So this is a progress that's,
Going on.
that is still going on indeed. But we can conclude that SNOMED was a big hero in this project. So by doing what we did, we improved the interoperability, both primary and secondary, but I'll give some examples next. And we are ready to exchange our data, but also use it for research, for example, an OMOP database, use those SNOMED codes there. There are many options. So a first example of primary use is an innovation project we did with the money from our government. And it's mainly to reduce calling and emailing between first line and the hospital. So in this case, a patient was in the hospital getting antibiotics or oncology treatments. The patient could go home and be followed up by a home nurse. So the patient was getting a prescription on paper, was going to the home nurse took care of the patient. If some parameter or something was wrong, then the home nurse called to the hospital maybe printed a new prescription, or I don't know, send an email. So everything was done by email, by calling, and by ticking in their own EHR, but nothing was going automatically. And so what we did with this project was when the patient was ready to go home, we sent the prescription and all the patient information in a FHIR document through the eHealth box of Belgium to the home nurse. Then the home nurse follows up on the patient, fills in all the parameters in their own system, blood pressure, temperature, symptoms. Then automatically those parameters go back to our EHR. They land in our care module, and we can do clinical decision support saying the temperature of that patient was alarming yesterday. Maybe you need to call, or maybe you need to ask the patient to come back to the hospital. And so everything goes automatically, and this is also because of the SNOMED codes that we mapped previously, because those SNOMED codes determine where in our EHR the parameter lands. Another example is the problem list consolidator, which is also an innovation project we did with the money of our lovely government. And for this, we had exchanged FHIR coded problem lists with SNOMED codes in it. So we used this SNOMED hierarchy to make decisions based on, for example, diabetes type 2 is more specific than diabetes. So we could use the SNOMED hierarchy in our problem, in our FHIR condition resources to make some improvements of our own problem list or improve the problem list of someone else. And then for secondary use, we could use FHIR as a data model, although it's not really a data model. You could see it as like a general structure, which is also useful for training AI models. But we in UZ Leuven, we also built our OMOP database from our FHIR resources, and we reuse the SNOMED codes that are in our FHIR resources, and then they flow right in our OMOP database. So those same SNOMED mappings are being used with the note that the intention on how they are mapped is a little bit different. So initially we mapped with the idea of what do we want to change primarily. So maybe sometimes the mapping needs to be revised for secondary use, but of course it's a very good start to begin with.
That brings us to the conclusions. It was a project that we've spent 2 years on it, so it's 20 minutes telling everything we've done is a fast train. So what did we learn? This project is only a super little project in the big universe of projects and FHIR and SNOMED worlds that is existing. We have a complexity with our legacy codes. Yeah, legacy codes are what they are. We didn't want to interfere with our clinical workflows, so they are what they are. We have to make the best of it. Mapping, it requires expertise. You need to know what you're doing. You need to know the SNOMED hierarchy. You need to know something from FHIR. You need to know a lot. You need to know little things from a lot, and that's not so easy. We've learned a lot. And then it's a very complex thing. You have to collaborate between IT, clinical staff, terminology. It's like Bart de Witte said this morning, it's a swarm intelligence. You have to put every intelligence of everyone together, and then you get a bigger part. So what's next?
Yeah, we still need to maintain all the mappings that we have. I saw yesterday that of all the more than 15,000 codes we mapped, already 72 were inactive. SNOMED codes can become inactive. And of course, there are still a lot of codes that we didn't map that we want to map in the future. So for that, we have work lists, but we're still trying to find out a way to actually maintain the progress that we have.
And then, yeah, maybe we can extend the primary use of SNOMED. Maybe we can use it to capture our procedures in our EHR system. We foresee possible difficulties with post-coordination. How are we going to use it in exchange with other healthcare providers? And maybe we can use the mappings we did to improve our legacy codes and to improve the standardization of the codes.
And then a thanks to our team and partners, which were mainly the 3 people of SNOMED team, UZ Leuven, Kim, and then Christian and Linda are in the back, who did all the mapping. IT UZ Leuven, Nexus Health, all the clinicians that validated our partnering hospitals, and then all the innocent interns I asked to map with us. Are there any questions?
So Thank you, Annabella and Kim. Those that want to ask a question, please, can you use the mic, which Annabella will probably share with you. I do like your slides as well, especially the SNOMED man. I was very impressed with that.
Is it on?
Mm-hmm.
Well, thank you. Congratulations for these mapping efforts. It's a lot of work. I just had a very concrete question about the attribute mapping technique in this FHIR. How do you ensure consistency? Do you have to come up with some sort of internal attribute coding manual and train people accordingly? Because it can be very difficult, because sometimes you have a concept that includes laterality, so you don't need to map it, but to add the laterality, but sometimes you don't, and you need to add as an attribute or severity or something else. How do you ensure that people are consistent?
We're only 3 people who are who are putting the diagnosis into our EHR, and for the attributes that are allowed to fill in, they are we do it in the background. Like if you have a fracture of a foot, you can set laterality on it, but you cannot do attributes that are not approved by the MRCM. So our clinicians can't choose for attributes that aren't allowed. And the list with values that is allowed to fill in is also pre-coordinated, we say. We predefine the list that is in it. And that's mostly because of our because of the technical implementation of how SNOMED is implemented in our EHR. So we have some boundaries there where we have to comply with. But it makes it, if we have laterality, we know laterality will only be used with lateralizable concepts. So that's the other part of it. You have boundaries in implementing it, but you also have the security that it's only used in a right way. I don't know if that's an answer.
It's a complex question. I
Yeah.
don't have the answer.
Does anybody have one more quick question at all?
Thank you for your presentation. We were wondering what type of concepts have you mapped? Indications, contraindications? I mean, you have mapped to disorder, to the disorder hierarchy?
We have mapped procedures, we have mapped disorders, we have mapped clinical findings, physical objects, substances. For example, if you have a procedure which has an implantable device, you will take a device from the physical object hierarchy. But even so, if you inject a kind of substance during a procedure, you can map it at the substance level. So it's a combination of the procedure in the procedure code and the substance in the use device code, the data element. So that's how we did it. So we did a lot of research on the SNOMED browser, and the most difficult part was the nursing observations, because it's really typical language. I do think every country has its own typical nursing language, and not every concept in SNOMED is already translated in the right Belgian Dutch. It's the Dutch, so it's sometimes very difficult to find the right concept for what the meaning is in our EHR.
So thank you very much, Kim and Annabella. Once again, great presentation. So that concludes this session. To our online delegates, you're welcome to remain here for our next presentation in the stream, or you may navigate to another session via the event lobby.